Good evening, all. Today's topic, which we are going to discuss, is on one of the most important things we need to learn in medicine, that is hyperkalemia. So, I have come up with one questionnaire here, a clinical scenario, which we are going to read. It is actually a case where we see it in our uh, uh, life, and then I'm going to tell how we manage such patients with hyperkalemia. So we'll start with the case here, so which is in the green box. So a 28 years old man is brought to the emergency department after a car accident. He was extricated after 4 hours. So he what he's trying to tell you is it has prolonged. So he must have bleeded a lot in that 4 hours. He did not lose consciousness and does not have headache or nausea. So which means to tell this, the question is actually to tell whether there is an head injury. So if there is any bleed in the brain, he's in severe pain. He sustained severe injuries to both arms and to the both the arms, and trauma team determines that surgical intervention is needed. Urine catheterization shows dark color urine. So pretty much it can be the urine showing dark color. Either it can be urethral injury or there is rhabdomyolysis due to the trauma itself. As you can see, the both arms are already injured. So his temperature is 100.4 degrees Fahrenheit. Pulse is 110 per minute, and blood pressure is 90 by 60, which is hypotensive. So he is bleeding. So we don't know whether it is internal bleed or it is a gross. He's bleeding from any fracture, or so we'll see what's happening. So the patient is alert oriented. So examination shows multiple injuries to the upper extremities and contusion on the trunk. So there is an trauma. There is trauma happening at the level of abdomen. So arterial blood gas analysis shows pH of 7.3. So normal pH would be 7.35 to 7.45. So this is acidic. So it is coming in those lines. So this is acidic, and bicarbonate is 14. So normal bicarbonate is 24 to 26. So he is telling again basically bicarbonates are less. Again, it's indicating that it is acidic. The E-fast scan of the abdomen shows no free intraperitoneal fluid, so which means there is no internal bleed. For the moment there is no bleed, but with time we never know. He might bleed as well. So most commonly there is splenic rupture, which happens, or liver laceration, which is very common to cause internal bleeds. So that is the reason we have a fast scan. So two large bore cannula are inserted and IV fluids are administered. Which of the following is most appropriate next step in management? So I even have provided with a set of lab values here. If you can see here, so he is already bleeding, which resulted in anemia, and he has hyperkalemia here. So the normal, if we all should know, right? So what is the normal electrolyte values? So normally the electrolyte values. So we would write fishbone diagram. So this is fishbone, so which is sodium plus charge. So all the plus charge will be here in this box, minus would be in this box, and waste will be here. So sodium will be 136 to 146. So another one is potassium. So potassium is 3.5 to 5.5. Chloride and bicarbonate. So chloride will be near 100, 115. Put, as I told, bicarbonate is 24, 26. So waste material will be BUN and creatinine. So if I write a ratio, that would be 20:1. So here we have sugars at the tail of which is 100. So I'm keeping, this is not fasting or postprandial. It is just a random number. It should be at least 100. So this is the normal value of potassium should be 3.5 to 5.5. So you can see that it is elevated here. So this is hyperkalemia. So this is hyperkalemia. Now, ECG was already taken, and as I wrote in the question that ECG is shown here, and the most common lead in which you need to look is lead 2, and you can see there is no P waves. So normally you need to see P wave, QRS complex, and R wave. So P, Q, R, and S, and T wave. So now, if you can see, P waves are absent here. You can't actually look for P waves here. There is no P wave. So P waves are absent, and you can see T wave is tall, tall T waves. You can see in the chest leads here. Sorry, this is a limb lead. So you can see limb leads is actually showing tall, even the chest leads. So there is tall T wave. So which pretty much says again that there is hyperkalemia, which is causing peaked T waves. So now, what is the why do we so much fear about potassium? So we fear potassium because eventually this tall T waves will cause arrhythmia, and to an extent where he might not survive, and even it might continue as a sequel of hyperkalemia. It may continue as ventricular tachycardia. So pretty much we don't want that to happen right now in this scenario. So there is a protocol which we follow. So I have got that, which is very commonly used. So the whole purpose of using protocol is it makes our life easy. So if you can see here, the value of the patient in this case was 6 point, if I'm not wrong, it's 6.3, 6.8. So it was 6.8. So which is so much elevated, and it might cause cardiac arrhythmia. So the normal value, as we discussed, it was 3.5 to 5.5, 3.5 to 5.5. So if you can recollect, as I told, the whole purpose of using this is to not to get confused. So we did obtain an ECG. The reason being is to see whether there is any cardiac changes here. So, and in this scenario, we did see tall T waves, so which were quite evident on the ECG. And lab values we wanted because we wanted to see if there is any other causes of hyperkalemia, and we also, and there is some few signs of hyperkalemic emergency, following which the treatment modality quite differs. So let's suppose we have a value which is greater than 6 to 6.5, so that is an emergency. So you see ECG changes, so that is an emergency. So what ECG changes are you expecting? So the tall T waves, absence of P waves, those changes. No, muscle weakness and paralysis. So pretty much this is due to hyperkalemia. So potassium causes muscle weakness. Both hypokalemia, both causes weakness and paralysis. So this is the reason, all the time we are concerned about electrolytes in elderly individuals, because we never know. This is a very small. This is a very small problem, and treating potassium really helps to reduce muscle pain. And if you so this is very important to know. So this is very these are the few things which actually tells ki this patient is in hyperkalemic emergency. And yeah, impaired potassium metabolism, if there is a CKD or if there is GI bleed. So most of these things causes hyperkalemic emergency. So let's suppose that patient has all these changes, ECG changes, lab value shows greater than 6 milliequivalents per liter, and there is weakness. So eventually we want to use this paragraph. I just want you to just see what is written here, and when is this used. Now 5.5, 3.5 to 5.5 in this value, and there is a cutoff value here which is 6 to 6.5. So this the kalemia which is beyond 5.5 and below 6, this need not is not an emergency, and you don't need to treat it very rapidly. But that requires a treatment which is quite slow. So this is that regime you want to follow. So once there is hyperkalemia, the best way, the initial thing you need to do is give calcium gluconate or calcium chloride. So yeah, this is the important element. We need calcium here. So why do we need calcium? So it is written here. You can see here. So calcium membrane stabilization. So which is because of calcium gluconate. If ECG changes, give calcium chloride or calcium gluconate. So actually potassium causes peak T waves, right? So and then eventually I told you it is going to go into ventricular tachycardia. So to stop that and increase the threshold and keep the cardiac membrane stable, calcium gluconate helps in this scenario. Now, if you can see, if you can understand, there is another modality which is very rapid acting is giving insulin. So insulin helps. So let's take a cell, and insulin acts on sodium, and it acts on sodium, potassium, ATPase. So it puts all the potassium inside, and sodium outside. So this is the reason insulin will be helpful for acute hyperkalemic emergencies, where it actually lets all the potassium inside the cell. So the only thing we want to give insulin is in hyperkalemic emergency you add with 50% dextrose. Now why is that the case? Because if let's think about it. If you give only insulin, then he might definitely treat potassium hyperkalemia, but also glucose goes inside. So eventually you should not become hypoglycemic. So sugar should not get low. So we add sodium 50% dextrose so that you maintain sodium you maintain sugars as well. So that is the reason intracellular potassium is shifted via insulin, and we use insulin as a second modality to reduce. So, but tell you what, so insulin is not going to stabilize cardiac membrane potential. It lowers the blood potassium. Calcium gluconate protects heart, but it is not going to alter potassium levels. It is not going to act on potassium. So the blood potassium doesn't changes with calcium gluconate or calcium chloride, whereas insulin acts on this, so by reducing this thing. So once it is done, you have given insulin and so calcium gluconate or chloride, you take an ECG again. So ECG, if you see the monitor, you should be able to see that potassium should be decreased, and T wave tall T wave should be coming back to normal. And also you should get a potassium lab again, so that to reaffirm, because insulin might dangerously lower potassium as well. So you don't need that, and eventually hypokalemia should not happen. Hypokalemia again would cause QT prolongation, right? And which eventually will become torsades. So again, you don't want to make potassium very low or very high as well. So you need to keep it in an optimal level. So that is the whole purpose. So hyperkalemic emergencies are for that reason. Now, Once it is done, you see, this is what is written. So serial ECG readings and repeat potassium and monitor for hypoglycemia because you gave insulin with dextrose. So that is the reason. Now repeat treatment if persistent hyperkalemia. So what he is trying to tell you here is, so okay, you used calcium and then you used insulin with dextrose, and yet your potassium is not treated. So this is a refractory hyperkalemia. So which means it is very resistant. It is resistant to the treatment. So what you want to do is, and so the end modality, you require some other means of reducing hyperkalemia. So that is, so here you can see, yes, simultaneously you identify what is the cause of it. So it can be CKD, or it can be GI bleed, or it can be rhabdomyolysis, it can be diarrhea as well, or it can be due to any drug. NSAIDs causes hyperkalemia. So so on. These are the main things which you don't want to miss. So review the contributing drugs. So NSAID, and consider treatment removing potassium. So the most important thing which we can see here is cation exchange medication. So what he's trying to tell you is, cation exchange medications are few things. It is called sevalimer. So this is a bead which contains calcium cation, right? So you take this by mouth and it goes inside the gut. Now your blood has pretty much more potassium outside. So all the potassium is taken into the bead and it gets attached to the bead, and this calcium goes inside, and now this calcium acts as a membrane, cardiac membrane stabilizer. So that is the reason we smartly used this cation exchanger medication, so that it should also benefit cardiac membrane potential and also reduce hyperkalemia. So that is the reason we use this. So, and also start having a low potassium diet. So that is obvious because you don't want to eat again something which has more of potassium. So that is the reason. Consider additional evaluation for suspected etiologies. Uh, Based upon the clinical suspicion, CK if creatine. So see what he's trying to tell you here is to see if the rhabdomyolysis is the cause of it. So in this case, in our clinical scenario, we had a patient of trauma. So once trauma is done, so let's suppose he has been in a scenario of trauma, right? So he had all the muscles. So all the muscle cells has plenty of potassium inside, right? And then there is trauma happening, and then there is rupture of muscle, also has CK, and this spells outside, and eventually it goes into the intravascular space. This is the thing he is trying to tell you. So potassium excess increase extracellular shift and increase extracellular release. So there are all the scenarios here. So you can see hemolysis, tumor lysis syndrome, rhabdomyolysis. This is our case where we are talking about. And also extracellular shift is because of type 1 diabetes, where you don't have insulin, and it all this happens in a reverse manner. So all potassium comes out and sodium goes inside. So you have hyponatremia and hyperkalemia. So this is what happens here. And in potassium excess, by other causes is by CKD. So it is due to kidney diseases or absence of aldosterone. So adrenal insufficiency, or due to drugs like ACE inhibitors, so RAS blockers. So this is how you are going to treat. Let's suppose you have so there is a patient with hyperkalemia. Uh, there is a patient with hyperkalemia, and then he has signs of palpitations, and ECG shows peaked T waves, uh, peaked T waves, right? And then he's going to, and also he has weakness. And you just treated this patient with, let's suppose, what do we treat in hyperkalemic emergency? So first would be potassium, calcium gluconate, right? And or chloride. And then you added insulin with 50% dextrose. Now, yeah, and then you took a lab, again you checked his potassium, and then yet it is 6.5. I mean, previously it was 6.5, and then it is 6.5, which means it is not actually responding to your treatment. So now what you actually do is, for refractory cases, it is yet an emergency, so it is not reduced. So you can't go into non-emergent modality here. So what you do here is do hemodialysis. So hemodialysis, what is the indications for hemodialysis? AEIOU. So which is very important. You should know this because this is one of the main reasons, and E is the one which we are using here. So electrolytes, electrolytes. This is uremia, ingested toxins, right? And this is acidemia, 7.0, right? And O is volume overload. Volume overload. That is what it means. That's the reason they use. So volume overload is one of the causes where we use hemodialysis as all these words are some of the phenomena where we use hemodialysis as a primary modality. So this is about hyperkalemia. So one of the most important aspects when we consider studying and also for exam purposes and in ICU settings where we pretty much see very often and need to be well versed with. Thank you so much. And if there is anything, you can write it down in the comments. I'll try to come with an answer. Thank you.